So this is, emphasising the importance of research. Prior to us publishing this paper in 2005, the only way you could diagnose PSP in the clinic was adhering to the diagnostic criteria I showed you before, which meant that about a third of people lived the whole duration of their illness as being told they have atypical Parkinsonism. We don't know what you've got because you don't fit under the PSP banner. This research, which we looked at pathologically proven cases, we found about a third of people actually didn't present in the way that I suggested is typical for PSP. They looked much more like Parkinson's disease for the first few years. Now, this group of patients had asymmetric onset of their symptoms, so rather than both sides being involved, which is typical, they'll have just one arm or one leg involved. These patients would often have tremor, which is unusual for Richardson syndrome, and a lot of these patients will respond moderately well to normal Parkinson's medications. Now this is in contrast to what I've just said about PSP. So you can see why there's consternation in the treating physicians about making a diagnosis of PSP in this group. Typically, and unlike Richardson syndrome, patients with PSP-Parkinsonism had no early falls. Their eye movements were normal right up until 4 or 5 years into the condition, and they didn't have any cognitive dysfunction. And this is the video of a patient who's now 8 years into the disease, so already past that this average life expectancy for PSP. She was looked after by a professor of neurology at St Mary's Hospital in London, which you'll all remember is where penicillin was discovered, and maybe Dr. Howard Florey worked there as well. This lady had unilateral rest tremor and a little bit of gait slowing in the first couple of years of her condition. She was treated with a dopamine agonist, a typical Parkinson's disease treatment. She responded extremely well to the point that her tremor disappeared and her walking normalised. After about 7 or 8 years, the professor became concerned because she started losing her response to the medications. Higher doses didn't improve things, and then her eye movements started slowing down. Now, she has got a slightly more upright posture than what you'd expect for Parkinson's disease. Pretty slow turning there. Most of you physiotherapists will recognise that. Reduced arm swing, and if we can just demonstrate the eye movements a little bit slow on the way down. Subtle, I agree, but over the following 4 years, she developed a full-blown PSP type picture, or Richardson syndrome type picture that I've shown you already on the video, where the eye movements were fixed, extension, stiff neck, blepharospasm with the eyes closing over, and indeed she had no response to Parkinsonian medications. Now, she's still attending clinic in London, and so she's now 13 years into her disease and would be expected to keep going for a while yet. This guy lived for 11 years. He was published in the literature and never developed the eye movement abnormality. You can see the rest tremor in the leg there. He has small handwriting. He doesn't have the extension in the neck. This is about 8 years into his condition. Good stride length, no arm swing, and his postural stability was perhaps a little bit more reduced compared to someone with Parkinson's disease with that sort of stride pattern. He had under the microscope only PSP pathology, and the people who were looking after him thought for the whole duration of his illness that he actually had Parkinson's disease. I guess we don't know in this case whether or not he had visual hallucinations, loss of sense of smell, REM behaviour disorder, but those sort of things might have alerted to the fact that maybe he doesn't have Parkinson's disease. And indeed, under the microscope, there was no Parkinson's pathology. So what about the other condition, pure akinesia with gait freezing? I was told in medical school this was always due to vascular Parkinsonism, so small strokes in the frontal lobe or the basal ganglia. But most of the patients that have this type of clinical picture, in fact, have PSP tau pathology. Now, the diagnostic criteria we put together for this was that this gait abnormality has a gradual onset, so a sudden onset would imply stroke, gradual onset implies neurodegeneration. Early in the condition, that is within the first 1 or 2 years, these patients experience gait freezing or freezing of their speech. And I'll show you what I mean by that in a minute. These patients never respond to levodopa, the most effective Parkinson's medications. They don't have tremor, they don't have any rigidity in their arms and legs, sometimes a little bit in their neck. And to exclude vascular disease these days. We just do an MRI scan and say, yep, there's no strokes. So this is the video of a guy who, under the microscope, has PSP tau pathology. So the first video is 6 years into his disease. Reasonable arm swing, not a bad stride length, pretty quick out of the chair. Now he's trying to walk up the corridor and watch the feet. They're stuck on the ground, can't get going, can't quite get going, and eventually gets going and labours a little bit, but the feet freeze up again. And that's his only problem. No eye movement abnormalities. He's been having some falls, but no rigidity, no tremor. Just checking his postural reflexes in the non-standard way. I believe it was done properly and his reflexes were reduced. So further 6 years down the track, now 12 years into the disease, very slow getting out of the chair. You note that he's got his walking stick upside down to use that as a visual cue. His feet going, his stride length's reduced. He's freezing a lot more often. He's got blepharospasm. The eyes tend to want to close over. And you'll see now that sort of 10 years, 12 years down the track, he's developed some slowing of his vertical eye movements. Horizontals, can't quite look up. This is voluntary movements, can't look down, very slow. And you'll see when we're testing for bradykinesia that he has very rapid but very small amplitude movements. This is a lot different to what we see in Parkinson's disease. And this doesn't project very well the voice, but he has rapid hyperphonia. He speaks very quickly but very softly. Again, a little bit different for Parkinson's where they speak softly and slowly. And these are clues that it's PSP tau pathology rather than Parkinson's disease. The biggest clue probably is that they don't get better at all with medications, and gait freezing, if it happens early in the condition in Parkinson's disease, always gets better to some extent with dopaminergic medications. These guys don't. Here's another guy who, 12 years into the disease now, paid a lot of money to go to Mayo Clinic in America to try and get a diagnosis, but it costs about $1,500 per day to see the specialist there, and a lot of people will just travel over there to get a specialty opinion. Finally came back believing us that we were right in London, where he got everything on the NHS and didn't pay a thing. So nice guy, Derek. So his only problem was the occasional episode of gait freezing for about the first 8 years. He's a bit more progressed now, 12 years into it. He's been asked to walk forward and he sort of can't swing the body, can't get the legs started, and really stuck to the ground. This is leading to falls at home, and we give him the visual cue here. He steps over it and he could walk a couple of kilometres there if he had the space, which of course you don't have in the NHS, which is why they don't ask for any money. So what's the difference between these conditions? Well, very importantly, if you can identify them early and think about them early, that's our job, then we can talk about prognosis, and that's important for a lot of patients. Okay, some people don't want to hear about anything about what's going on, but others do want to know and plan things out. And along the top, this is a survival curve, again, like a printout from your the tuning guy at the car centre, telling you all about what the car's doing. The survival curve, 100% survival at the start, of course, 25 years across the bottom. So the green curve here is the survival of patients with Richardson syndrome, and about 50% of people will die after about, or in this case, about 6 years. Patients with PSP are on the blue line, and you can see that some patients live out even out to 20 years. So same pathology in the brain, different clinical syndromes, different rate of progression, and this is important for therapeutic interventions and counselling as well. Not surprisingly, if you're green, that is older than 70, or blue, younger than 60, the survival's a bit different. So if you're older, your survival is a bit less, which you can't pick on any one person and say what their survival exactly is going to be, but you can imagine that the accumulation of disability is going to increase at a faster rate if you're older.